So welcome everybody. Thank you for coming to our AOT Community of Practice this month. If you received our reminder email, then you know today we have Megan and Jody from Oakland Community Health Network here to kind of give a county profile, talk about their AOT program, their experience with getting this AOT program set up at OCHN. And we'll have a portion after they do a bit of a presentation for questions and answers, of course. But before we jump in, I want to state at the beginning of the call that any opinions and views shared today by our presenters or by audience members are those of the individuals, and they do not necessarily reflect the views of the Center for Behavioral Health and Justice or Wayne State. And as always, we want to plug our monthly Q&A sessions, where twice a month we have Dr. Scott Smith. Scott, give a little wave for me, please. Just wanted to make you do that. He's at the Q&As, available to answer any AOT related questions. These are a great resource for natural supports and people on the orders as well, not just the workforce. So it's a drop-in. You can come anytime within the hour span that they're going on. As AOT gets more attention across the state, more questions are popping up. So please feel free to share that information internally with community partners or anybody else who needs guidance on AOT. The dates for those should be posted in the chat, but for August, we have a Q&A on Monday, the 10th from 11 to 12, and on Wednesday, the 19th from 2 to 3. So if you have questions today that aren't answered, please feel free to join the Q&A session. And you're more than welcome to email us directly, as always. And then I also want to shout out a few new resources on our toolkit since the last time we had a COP. We have a psychiatrist roles in AOT, a brief that just outlines the role that psychiatrists play in this process. Because our last COP was on Clubhouse, we also have a resource on the Clubhouse model. And we have a new 2025 brief that provides an overview of court-ordered mental health treatment in Michigan. Check those out if you are interested. Okay, so without further ado, I'm going to go ahead and pass it over to Megan and Jody to share more about OCHN and their AOT program.
Good morning. Thank you. I am Megan Hebert. I am the project lead for our Assisted Outpatient Treatment team here in Oakland County. Jody, you want to introduce yourself before we start?
Yep. Good morning. I'm Jody Gorenflo. I am the coordinator of the Assisted Outpatient Treatment team at Oakland Community Health Network.
So I'll start with a little bit about the history of AOT here in Oakland County. So we've actually had a probate court liaison role since 2012. He's actually on this call. It's Mac Holman. So that role was actually delegated to a contracted entity for quite a long time. It was in 2019 that OCHN's leadership really decided to take a deep dive in understanding what the mental health code says we need to do, trying to identify some gaps, ways that we can better support the residents of Oakland County, which led to us starting to track orders from Oakland County Probate Court, and then eventually working with them on creating a system to submit treatment plans. In 2023 is when OCHN officially brought the AOT coordinator role. So that was a brand new role that they created. And the role was really, it started off to try and get a better understanding of what AOT looks like here in Michigan. So we were very beneficial and very thankful. I was able to coordinate with Jenny, who was over at Genesee. We were able to work with CEI, work with DWIN, and work with Wayne County Probate Court to really get an understanding of what their AOT programs look like. If we didn't have that, I don't, they were huge in helping us understand what it looks like and what it could look like here in Oakland County. During that time, we also applied for 2 grants. We got a grant from Michigan Department of Human Health and Services, and then we got a SAMHSA grant, which has allowed us to expand our team greatly. So we started off with just literally, the probate court liaison role, which was with a contracted entity, the coordinator role, and has now grown to having several staff members. I will take it over to Jody, and she's going to talk a little bit more about our team.
So this is what our team looks like. This is our assisted outpatient treatment team. We actually have 8 team members. So we have the project lead, that's Megan. We have our probate court liaison, that's Mac Homan. The coordinator, that's me. We have 3 monitors, Sahil, Kaylee, and Amber. And we have 2 case managers, Manisha and Al. And you guys have seen them around the community of practice and then in our other meetings as well. So, as far as roles and responsibilities go, this is really a testament to our leadership and also to Megan. Like they built these positions from ground up, not just from, like she said, case consulting with other counties and other partners, but also within the grant confines and also within OCHN framework as well. So, Megan is the project lead, as she mentioned. She is our primary contact for our provider network, our crisis provider, which actually some of you used to know our crisis provider is Common Ground. So, we don't say that anymore because we've taken over crisis services. I don't know, we'll have some units up and running soon at our Resource and Crisis Center. We don't know the official name of them yet, but as of right now, they're Oakland Community Health Network Crisis Services, and it's still in the exact same location. We also, have a really close relationship with probate court, which Megan is part of, and she also is the point contact for any other entities or partners, really anybody, family members, anyone that works with individuals placed on an AOT order. Megan also provides a lot of clinical guidance to the AOT team. And so, since she is the lead, she's the person that we all go to when we have clinical questions, clinical issues, when we need to troubleshoot things. We start with Megan, and then if it goes from there, then we loop in our supervisor as well. And Megan provides system-wide education and training. And, I feel like we talked about it one of these last meetings, something, and she'll talk about it a little bit that's unique to us is that we do a lot of trainings and we offer trainings to our providers on a regular basis. Megan might be able to tell you how many she's gone on. So, like in a calendar year or in like a fiscal year or a goal year, we go out many times, either virtually or in person, to meet with our provider network or just to provide education and training. And Megan is really sort of like the brains behind that operation. So we have a court liaison, the probate court liaison, that's Mac Homan, and he has been doing his job for many years. I think it's at least 20. Mac, tell me if I'm wrong or put in the chat if it's less than that. But we did bring him on. He does all of the alternative treatment reports. So he writes all of the reports for individuals who are hospitalized and who don't end up deferring. I will say, I want to give Mac a huge shout out because when he's gone, I do his job. I fill in for him, and it's nuts. So since 2012, thank you, Mac. So he is just cool and calm and collected, and he's like a real asset to our team because it is very complicated to coordinate ATRs for sometimes a dozen hospitals on one docket. So he will have on one week on one docket 12, 11, 12 hospitals. And so he coordinates all of that. He calls the providers if they're open with a provider. He calls the hospital to get information for the ATRs. And obviously we know it's a difficult job. It's very entailed. So he doesn't always get response, but when he does get response, he's able to put that information in the ATRs. I do think that he's been doing it so long in our county. He has a great relationship with our judges, and he's very well respected, and the work that he does and the information that he provides is very well respected by our judges in our court. He attends the review hearings, and so those are all the hearings that happen in our county. It's Mondays and Thursdays, and he attends all of those. And sometimes, I mean, Mac is also up for like being put on the spot, like, hey, do we have information about this person? What can we do about this? And so he will testify in court if need be. He's also always available for system navigation for members of the community and providers. So he does get contacts regularly from family members, from providers, from hospitals, asking questions, asking for information, trying to troubleshoot things as well. So, Mac is just a general, like, sort of system hospital court expert when it comes to that. So I'm the coordinator. I receive all of the AOT orders. We do have a system. It's an automated system, and I receive all of the orders. I input them into our spreadsheet. I collect all of the information. I look up the individual's Medicaid status. We collect quite a bit of data, and Megan's going to go over that in a little bit, but it's actually a pretty complicated system, and it's been going since the beginning of the program. So I do that. I do that piece, which is just entering all the information, going through the information, and putting due dates in so that and this is what the whole team works off of. So we have multiple spreadsheets. Every team member has their own spreadsheet or smart sheet. I mean, we have a lot of data collecting, but this is the main spreadsheet where we collect all of our data for the orders that come in. When an individual needs to be connected to services and they have Medicaid, I complete the access screenings. So that's the eligibility screenings in our county. And then we also have something called a Justice Liaison Assessment. This is essentially, and access screenings look for everyone, they look like a biopsychosocial, essentially, suicide screening, ACEs, and just a complete biopsychosocial. The Justice Liaison Assessment is for individuals that are not eligible for Medicaid or don't have Medicaid. And it essentially looks very similar. It has a little bit of extra substance use information. If we get extensive substance use history, we might go on and do a short assessment like the TAPS to just assess if the individual needs some substance use connection as well. And so uniquely, this is another unique thing, and I remember this is not in our presentation, but when I was looking at it, I remember that we actually have had an individual recently who does have Medicaid, and he and his guardian were just really struggling with their service provider and also just what they wanted. And so even though this person had Medicaid, we were willing to complete an access screening, or in this case, it would have been a Justice Liaison Assessment to potentially determine whether or not they'd be eligible for our caseload. So Justice Liaison Assessments are specific, but they look like access screenings to determine if you can be on our caseload because you're not eligible to be connected to a provider. We all know that individuals have private providers, people on Medicare, people with private insurance. And, coordinating with private providers and Medicare providers is much more challenging than our Medicaid providers because we are directly already connected to them. I connect individuals and their guardians to community-based services. It's, care coordination. So I do a lot of care coordination and system navigation, specifically with guardians. I don't know how it is in other counties, but a significant number of our individuals in Oakland County on orders have guardians. And so I spend a lot of time with guardians, coordinating services, trying to help them navigate the system, giving them information. And then I submit the treatment plans to the probate court. We have an automated system in Oakland County. Now, that is a testament to our leadership and to Megan. They developed in partnership with our court system, they developed an automated system. So the court sends us our orders and they send it with a link, and they've developed an automated response system. So essentially at that 31 to 33 day mark, I send a response to the court telling the court what the individual is doing. We've come up with a system, which is submitting a treatment plan, but we all know lots of individuals don't have treatment plans for whatever reason. So we have come up with a system with 20 additional exception reasons. So I look at every single order, and when it's time to submit the response to the court, I either submit a treatment plan or I look at which one of the 20 exception reasons fits that individual, because we want to make sure that we are reporting accurately to the court what the individual is doing at that 31 to 33 day mark. That's sort of like our way to ensure that we're following the law and that we are, thank you, um, and that we are, complying with the mental health code on our part. So our case managers, they provide case management to non-Medicaid individuals and those who aren't connected to an entity that can provide case management. We know a lot of private providers don't offer case management, so our case managers can help those individuals. They work with the person's support system. They work with the treatment provider, whether it's private, whether it's whatever. They're always trying to connect, with that individual's provider to work with them side by side. And then they also report non-compliance. They'll do change of venues. They'll do modification of order requests for individuals on their caseload. Megan can probably expand on this a little bit because I'm not in the case management meetings specifically, but our case managers do more than just this. I want to make sure that I say that. They do a lot of things now. They're helping with some SAMHSA grant requirements, and they are also sort of catch-alls. They do a lot of extra stuff on our team. They work with data, and they're there to just, pick up slack and just be our support, our clinically supportive staff as well. So our monitors, we have 3 of them. That's Sahil, Amber, and Kaylee. They are our main contact regarding all of our deferral conferences. So we have a deferral smart sheet. Again, another thing that I think is super progressive and unique to our program. Maybe it's not unique to our program. Maybe a lot of jurisdictions have that as well. But we have a deferral smart sheet, and we have a good amount of hospitals that use it. And it is essentially a form. We'll show it to you a little bit more in depth. And it is just a way for them to enter the deferral information into the smart sheet. We all know that deferral, we know how hospitals work. We know how it is on those units. And we know stuff is just like, it just coming up. It's just happening, and you can't help it. If someone doesn't want to get out of bed, or if the liaison is ready right this minute, or the attorney says we got to go right now, it's chaotic. And I will say that as well, because even when our monitors are out or they need backup, and I fill in for those deferral conferences, it gets hairy. And so they attend all the deferral conferences, and they're also the main contact. So if the hospitals want to reach out to them, then they can do some of that coordination piece. And our monitors are phenomenal. I want to give them a shout out as well. And they're extremely responsive. They are just very dedicated to what they do. And I personally think, Megan can say yes or no, but I think they have a great relationship with our hospitals and our hospital liaisons. They also assist with renewing AOT orders, reporting noncompliance, changes of venue, modifications. I mean, essentially, you think about it, they monitor the individuals throughout their order. So they're picking up on anything that's happening on the order. So that could be any of these things. That could be renewing. That could be individuals are noncompliant. That could be, they got word that the individuals moved to a different county. So I feel like the monitors, they are constant, Megan too, but the balls in motion are constant for the monitors. And then they monitor, like I said, the individuals throughout the duration of their order, and they make sure that they're making that consistent contact with the treatment provider as well. So this is one of our promotional videos. We actually made this a while ago, and we're actually really proud of it. This is one of our participants, and this is Al, our case manager. So I'll let you go with this.
I dealt with a lot of going in and out of facilities throughout the years ever since I turned 18. I was at one point that nervous person when you'd go through a court-ordered treatment and you'd have these extra hurdles to go through. But this Oakland Community Health Network process with AOT really makes it seamless.
The initial contact is our probate court liaison, who attends all of the hearings with the individuals. They write something called an alternative treatment report, where they basically take into account what's going on with the individual and suggest some things that might be appropriate for them.
The role of the probate court in the mental health process, in AOT specifically, is to protect the individual's rights as well as the process, and is to ensure the process is fair for the individual and that services are provided to the individual to help them be successful.
And at the hearing, they would have ability to speak for themselves, the attorney would speak, family members, mental health professionals, and then everyone's voice is heard to make a decision about whether they're appropriate for AOT.
The law requires that the court consider the least restrictive setting for treatment for the individual. While that might be in the hospital, might also be in the community, and information is heard before that is ordered which setting is the most appropriate and the least restrictive for ongoing mental health treatment.
There are different things that could be on an AOT order, whether it's therapy, medication management, housing support, so it's really applicable to what each individual needs, and it's different for each person.
Zoom provides the ability for people to appear in perhaps a more comfortable setting as opposed to the courthouse, which could provide safety for them and all involved.
After an AOT order is issued, people might still be in the hospital for a remaining balance of days. They may go back into the community. Sometimes they're not connected with a provider immediately, so the hospital or us work to connect them with whatever provider they may need, and then the process really begins of working with your treatment team, us being there to support them, and everyone kind of working together as a collective unit to then work towards whatever treatment goals they have.
We actually kicked it off on our first meeting, which was actually at this same table in the same house. So we kicked it off pretty well, and we got to know each other.
We check in with them regularly, and it's not just about how they're doing with their treatment. Of course, we check in to make sure that they're engaged and they're compliant with everything on their order, but it's also just to see what their needs are in their everyday life, connect with them, build that rapport with them, so that way we can work with them and not just seem like someone who's there to just make sure they're being compliant. Like, we want to be there to support them.
We usually try to start off with the AOT assessment. The AOT assessment is a tool that we use where we can actually get to know the person on a deeper level, just like who you are as a person, and then we build our treatment plan based off of that assessment.
Getting to know what the program is and what we'll be even looking at and who Al is was a great first step.
My job as a case manager, specifically for assisted outpatient treatment, is definitely to provide support, education, and resources. When you're getting introduced to a new individual, they may not understand what exactly is going on with their court order. So I usually try to start with breaking down the court order and showing them how this is going to go for the next 6 months, basically.
We want to make sure that we're all working together to understand what's going on with them, their successes, what they're doing well, what they might be struggling with, what they might need.
The resources that they were offered and gave me kind of really helped me out in a bunch of different time periods throughout the 6 months. There was times where I didn't have living, there was times where I went back to the hospital or transitioned or was just going through a lot of different things, and the resources was a great outlet and gave me a lot of good conversations and phone calls to have with different networks and places that I really needed at the time.
We like to give the court an update as to how an individual is doing to make sure that we're all working together.
I would want people to understand that the court has a small role in a bigger process, and that the hearings for mental health treatment are not punitive, but to have an order for both the individual to get treatment and comply with treatment, as well as the mental health agency to provide that treatment for them.
The AOT program and Al really helped me make sure that I was going to get what I actually wanted for my future, and that was one of the major things that I greatly benefited from with the AOT.
If I can get you to a point where you can be engaged in services without me, even though it'll be tough to walk away, it'll be a good thing just to know that, I played a part in someone's life and to helping them get better.
They really do make it really seamless and easy for you, so you'll definitely get through it and find that one thing that you can do best for your mental health is to sometimes accept additional help.
Okay, before I pass it over to Megan, we'll just talk a little bit about our relationships, which I am very proud of. I think our team is very proud of. So we have over 40 law enforcement departments, including the Sheriff's Department in Oakland County. We host a lot of interagency and outside committee meetings to discuss our policies and procedures. And it's actually a pretty involved situation as far as working with our police department and our co-responders. We offer support with our complex high utilizer and public safety cases. And, we tackle, issues surrounding information sharing, executing pickup orders, and then the probate court processes. So our co-responders, I don't remember how many we have, but quite a few, are social workers and or LPCs embedded in our communities in different jurisdictions. And so Megan works really closely with our co-responders on a regular basis, especially on those high utilizers and our public safety cases. We have a community behavioral threat assessment and management program. We call it BTAM for short. This is kind of the baby of our medical director, Dr. Posios. He has a background in forensic psychiatry. And so we started this program. It's a multidisciplinary, it's an evidence-based approach to identify, assess, and manage, concerning or dangerous behaviors before violence occurs. We have over 20 contracted hospitals in Oakland County, and there's a link in here to the deferral smart sheet. I don't know, Megan. Yeah, there you go. So we have over 20 contracted hospitals in Oakland County, and we work closely with those hospitals. This is kind of what the deferral smart sheet looks like if you just want a page down there, Megan. You can see it's like it's very short, it's some basic information, and honestly, I think our monitors would probably just be happy to have a name, a hospital, the time, and get some advance notice. But this smart sheet has been really helpful and really integral in maintaining sort of continuity in attending deferral conferences. And of course, we know our hospitals work with many jurisdictions, so we appreciate the ones that, work with us and that work with this deferral smart sheet. We have a really good relationship with our probate court. That kind of started at the beginning of the program. And that was when the probate court reached out to us and said, hey, this was before our program developed. We really need to be doing this. The mental health code says we need to be doing this. So our probate court, we have constant communication with our probate court register. She's sort of our go-to for our judges and our judicial clerks or assistants. Sometimes we do communicate directly with our judicial clerks or assistants, and our mental health staff in Oakland County at the probate court, we work with them as well. And these are very good people, very communicative, very responsive. So we have a lot of success with that. And again, our court register, her name is Barb. You all might have seen her in some of our meetings or some of our presentations. Barb Andrucci, she is our main contact. She's the probate court register. And then, our contracted providers. So all of the providers that we contract with through our Medicaid services, we host monthly, quarterly meetings. We offer to go out and host trainings, as I said. And then we are constantly in contact with them through our monitors, case managers, Megan and I, trying to help people with case coordination, service engagement, and just general clinical support. And I'm going to turn it over to Megan.
So I'm going to talk a little bit about sustainability. So obviously, whenever you get a grant, that's one of the things that you're supposed to focus on. So with our SAMHSA grant, our leadership, especially our justice director, has really taken into consideration how we can find ways to sustain our program. So one of the ways that we're doing that is we're obviously looking at the services that we're providing, what of those can we bill? So, with our case managers and Jody, our coordinator, those are two roles that they have some things that they do that we can potentially bill for. So that's something that we're exploring. One of the other things that our program evaluator and our director are working with our IT department on is developing what's called a cost analysis dashboard. So this idea actually came from, pretty sure it's Alabama. So they have a really successful AOT two teams down there, and they've presented a lot on it. And so what we're working on is developing this dashboard, utilizing our data to show how individuals who are placed on an order long-term reduce spending in other areas. So that's kind of a big undertaking that we're working on, but it's basically to help identify the larger benefits. So by having our team in place, how does that reduce potentially hospital days? How does that reduce contact with law enforcement, jail days, that kind of a thing? And then obviously we're going to hopefully take that, bring it to some of our stakeholders to see about cost sharing. That's something that we haven't done, is talking to different stakeholders to see who's willing to try to help. And I know that that's something that they plan on doing. So we are collecting quite a bit of data. So we have to collect data for our MD-HHS grant, which we're obviously working with the CBHJ on, and then we're collecting data for our SAMHSA grant. So our data, we put all of this information is actually in our electronic medical record system, our EMR, which is Odin. Hopefully you all are familiar with PCE. It's one of those. And what will happen is once it's entered into Odin, Power BI is what we utilize, actually pulls the data and then creates different dashboards so we can keep track of what we're looking at. So our program evaluator is very heavy in our data. That's really her expertise. So she does that along with our director of justice initiatives. But some of the stuff that we're collecting is we're looking at the type of order a person's on. We're looking at if they've been screened by access for eligibility for services. We're looking at how many of those individuals actually were already in services before the order was put in place. So, how many of those individuals are working with one of our contracted providers, not those that necessarily got into services because of the hospitalization. We're keeping track of some of the services that are ordered by the court, including actual hospital days and some of the, screening tools that are utilized. So we're looking at What standardized tools are they using that reference, suicide risk or trauma or substance use? We're trying to track the notices of noncompliance, how many are submitted, any requests to modify an order, staff that are working with people who are on an AOT order that are trained in evidence-based practices, individuals' insurance, their gender identity, race, their Hispanic or if they're Latino ethnicity, their education level, veteran status, some of their employment and if they have any disability benefits, their income, living arrangements. We're also looking at some public health outcomes. And then we're looking at, and this last piece is big from SAMHSA, it's the infrastructure development, prevention, and mental health promotion. So this is basically a reporting tool that SAMHSA utilizes to see performance across certain categories to see how well a grant is doing. So what we have to do is we actually are utilizing a tool called the support. We have to do it at several increments while a person's on an order. We enter that into SPARS for data collection specifically for SAMHSA. So just some data that we have. In fiscal year 25, we had a total of 529 orders put into place. So far to date, for fiscal year 26, we've had 335. I will say that's not accounting for individuals who were placed on an order this week. In June, we had a total of 36. In July, so far, we've had 17. I will say that typically every month we have anywhere from on the low end, I would say 30, high end up to 60 new orders, new individuals placed on an AOT order. We're trying to track those who are on a deferral. This data is kind of rough though, because our IT department is still trying to work out some of the kinks. So we believe roughly in 2025, we had 765 people defer. And then so far in 2026, we've had 412 people defer. One other thing that we're also doing is a part of the SAMHSA grant is we're sending out surveys. So our program evaluator sends out surveys via mail at different increments while a person's on an order. It's really neat. It's just a QR code they can scan and complete. We haven't had a ton of responses. We've gotten 34 so far, but we have been happy to see that there's been a mix of positive and negative. So it's not, just negative, which is always good to see. Some of the challenges that we've had, which I'm sure are very similar to a lot of other programs, but like Jody mentioned, we have a really large hospital network. We're a big county. So when we first put when the AOT coordinator role first was put into place, we really worked on starting those connections with the hospitals because we knew we needed to start attending those deferral conferences. So because of that, I feel like we've done a really good job of, being able to be looped in to, I would say, the majority of the deferral conferences that are occurring for Oakland County residents. One of the challenge though is we still have some that slip by us, but we get very last minute notice. I mean, our poor monitors will get a 5-minute notice, sometimes, a day. So, and it's really tough. We've had a lot of conversations with the hospitals, with the court about trying to make some changes, but it's tricky. So we do the best that we can to try to attend as many as we can. But that's where that smart sheet that we utilize is so incredibly helpful. So if we miss a deferral, the hospital's putting the information in there and we can keep track and then loop back around to understand what happened. One of the other barriers that we have is and I'm sure every county sees this, but people who constantly just keep deferring. They get released from the hospital, a new petition is completed, so they have that right to defer again, according to our probate court. So instead of, our hospitals doing demands when they should, they're doing just a new petition. And so that's one thing that, we obviously would love to see differently to try to stop that, constant cycle of these individuals going in and out of the hospital. One other challenge that we have is we do not have a in-house psychiatrist or psychologist as a part of our team. I would say that's a big frustration of mine. It has been from day one because we run into situations where we have individuals who don't meet criteria for hospitalization, but should be placed on an order, but we can't get them to get that evaluation. And then we have no psychiatrist to testify. So that's one thing that our leadership is very well aware of, that, with us bringing crisis services back in-house, the hope is that we can work collaboratively together to potentially utilize some of that support, hopefully. But our leadership is very well aware of this and knows that it's something that we need to work on. Lastly, I would say, a big challenge that we've had is our judges. We have 4 judges. That comes with different personalities, different views of interpretations of the law, different philosophies, and they all have come in at with different background and training. So we have two that have been there for quite a long time. One, he is actually going to be aging out very soon. We have a new one that was appointed by Governor Whitmer. And then we have another one who was elected, who's very new. But a lot of the newer individuals just like we all know, there's no training for these judges to go through, so they don't have the understanding that they need. So we run into where there's issues where maybe they're interpreting it a different way. So it's really tough for our providers when they come to us and say, "Hey, I don't understand. Why was this person not given an order? Please help me understand." So I think we are constantly trying to support the judges. We send them trainings, offer to meet with them, ask to meet. We've had 2 meetings, which is good. But it's still one thing I think that we struggle with. The other thing is that we don't have any review hearings here in Oakland County. When I've talked with the court, we often get told that there's just no time. And I think part of it too is that there's just maybe not some buy-in from the judges. Surprisingly enough, Judge Richards actually did schedule a review hearing in August for one individual. This will be our very first one, so we have no idea what to expect, but we're going to go and see how it goes. Some of the successes that we've had, which we've had quite a few, and that speaks to, I think, our leadership here at OCHN, who's really um, was able to recognize the importance of AOT and how we needed to really make it a priority. And especially to our director, who really, she wrote our grants. And our SAMHSA grant, the scoring that we got was, we were very lucky. We were very happy. She put her whole heart and soul into that. But I would say those are kind of some on the big scale of successes. But some of the smaller ones, really our relationship with the contracted hospitals, that has taken a lot of time. But I think they have really grown to understand why we're here, why we're attending. We really try to come at it like, how can we make it easier for you? We're trying to help you guys so these individuals don't keep coming back. And we've seen, our monitors have attended these deferral conferences, and we've had situations where attorneys were not providing the information appropriately to the individuals, treating them with, honestly, just complete disdain and a lack of respect. And some attorneys who were not at all appropriate in these deferral conferences. So I'm so glad that we've been able to make this happen, because we've been able to advocate for these individuals. And that's the whole point of the deferral conference, is really to respect their rights. And so I think having us there has been huge, because when we've had those issues, we're able to bring that back to probate court and say, "Hey, we've got some issues," and they've been gracious, and these judges have been handling it right away to recognize, okay, we're going to reach out to the attorneys and address this head on. So I think that has been a huge success, is just having the hospital support and their willingness to do that smart sheet. Obviously, another one is really our data collection. Our director, data is her passion, and I think it's so helpful, because to really sustain a program, you've got to show the hardcore numbers as to how this is beneficial. You can't just say it. And so I think that's where, having the data that we're collecting, working with the CBHJ, has been helpful in that we can really show, what we're doing and how we're impacting the community. We've had, since our program has grown, the amount of collaboration we've gotten from our contracted providers, and even, Easter Seals Mark is one of our providers, and they have a CCBHC. The coordination and collaboration we get just from that side, that's not even a part of OCHN, has grown so much since we've started this program. And, we get emails daily asking questions about deferrals, paperwork, I need help with this person. And that speaks to how our providers are recognizing the importance of our team and how we are here to support them. I always try to tell them, like, we are here to make your job easier, not harder. Tell me what you need. How can we help you? We are here to work collaboratively to better support these individuals in the community and help them stay in the community and get the support that they need. So, that's one thing that I'm really proud of. And I think it speaks to just our team in general, how well we are with just approaching, interactions with our providers, being open, being responsive, getting back to them as soon as possible, which, is something that we're very proud of. And lastly, I would say just our compliance with the mental health code. We have tried really hard to really do what the mental health code says. We're not perfect, but we are attending those deferral conferences. We are submitting notices of non-compliance. We are, keeping track of those change in venues. And I have to say, DWIN and the Wayne County Probate Court and Macomb County has been great. When we have situations where we need to change the venues, I mean, their teams are on it. We're collaborating, we're talking, and it's been so nice to have the support of our local counties to be able to, okay, let's work together. What do we got to do? So that's, I think, just another big success of our program. Just some of the things that are pretty distinctive to our county, I will say, like Jody mentioned, is we have such a strong partnership with law enforcement, and that speaks to our co-responders, our CIT training. Our co-responders, like Jody had mentioned, we work very cohesively together, and they're able to assist with pickup requests. They're able to assist with pickup requests that come from a notice of noncompliance, and really let law enforcement know, hey, this paperwork's okay. Like you can take it, which has been a barrier in the past. Another thing is, we have several teams, or, here at OCHN, thought I heard we're up to like almost 500 employees. But when you get a bigger, company, you can have teams that are super siloed. And I think, we have worked really cohesively with our hospital liaisons, which is a separate team, and our customer service. Our customer service is great. We mail out letters to individuals who are on a deferral, on an AOT order, with the customer services phone number. They let us know right away. They're calling us when they're in an individual's chart in our electronic medical record. They're seeing, the different things like banners that we have to show that they're on an AOT deferral or an AOT order, and they're connecting with us right away. So that speaks to, I think, just as a whole, recognizing how we can work together, even though we do, separate jobs. And then we have our hospital liaisons, which are huge. They are so helpful. This team is able to assist with individuals who, if they're stuck in the ED and they can't find placement, those high risk individuals, they'll, assist with collaborating with the ED, collaborating with, the different psychiatric hospitals to figure out how we can all work together to help this individual. And obviously, our case managers, I think, a really cool niche that we have is that they can provide services for those who, don't have Medicaid. It's something that, we have individuals who sometimes have a private psychiatrist and they don't want to go to a CCBHC. They want to stick with who they have, but they need just a little bit more support. And that's where our case managers can come in and provide that. And then lastly, the trainings that we provide. So we have been so gracious because the CBHJ has assisted with all of our trainings. But we've been able to have 2 half-day trainings on AOT, and we have our upcoming full-day training in September, which we're super excited about, to really expand on the half-day, to help people here in Oakland County get a better understanding of what AOT is, how to utilize it, how to do the paperwork. So that's, one thing that we're really proud of, that we are continuing to try and do more of to better support our contracted providers and just community members. These are just some resources. So on our OCHN website, we actually were able to revamp our it went through a huge overhaul, but with that, we created a whole AOT section, which is really neat. It talks about AOT, what we do, what it is, it provides some resources. So there's a link directly in this, and then we obviously have just the link to Oakland County Probate Court. If you guys have any questions, the best way to contact us is really this general AOT email. It's something that I monitor on a regular basis. If I take PTO or I'm out, the rest of the team helps, but we are great about responding right away, or at least letting you know, hey, I've got the email, but I need a minute, I need to figure some things out. So that's the best way. If you have any questions, any concerns, feel free to utilize that. We've also included Jody's direct contact information and mine as well. And that's pretty much all I have. So if there's any questions, I got to love to see the chat.
Number one, this was fabulous. Thank you very much. I'm always curious to hear and learn how other counties are managing their AOT program, and you guys are super organized, and also provide a little bit of validation that where we're trying to push things in a certain direction, that you're doing it, and it sounds like it's working really well. So I did want to say that. I did have a question about the deferral conferences. It sounds like OCHN handles all of the deferral conferences. Okay.
Yes. So, and the reason
Yeah.
behind that is when we were doing the research in the very beginning, when I was in the AOT coordinator role, I knew that our providers they weren't going to attend. So I really did a push and said, I really feel like the deferral conferences should be done in-house, if possible. So I felt that if we could go, then we could get a better idea of what's going on. And so, OCHN agreed. And so we attend those deferral conferences, and then our monitors then are coordinating with the treatment providers. We're letting them know the outcome. But this way, it kind of frees up the time so the providers don't have to do that. Now, I will say there's obviously there's some, that's not always the best because we are just meeting these people versus like, a treatment provider might have that connection with the individual, but we try to look at it as a time where we get the person's information. We try to get their address, their phone number, confirm their date of birth, get an emergency contact and verbal permission to coordinate with them. And then we do a follow-up. So we'll call 15 days later to say, hey, how are you? What's going on? Do you need help? Just to kind of try and help that, transition out of the psychiatric hospital.
Mm-hmm. Yeah, and I can definitely see the pros of that because we do about half of them. Like we'll get about 200, I would say like last month I counted up, we had over 200 deferral conferences. Now DWIN separates it a bit because if they have an outpatient provider, we have them do the deferral and we just make sure that the hospital provides enough notice. And then we do the ones where there isn't a providers and usually ends up being about 50-50. Yeah. Okay. So that I find that interesting. I do see the pros of that if we had enough staff. And then the second piece I was wondering about is we tried, and part of this is the volume that DWIN has, but ideally we would like to do this in the future where we do have case management for the non-Medicaid individuals because we get quite a few of them. And so we will send them to a CCBHC, but then I don't know if they have copays or anything associated with that. And truthfully, every now and then you'll get someone where they may not need like super classic case management. Like they might just be in kind of a dark period right now, but they have a strong family system. They have resources. They see their therapist and their psychiatrist. We would like to provide case management for those individuals so they don't have to try a CCBHC if it's not feasible. But with that being said, how do you guys handle like the billing piece? Because it sounds like you would like to bill in the future, but ultimately right now it's not being billed, right?
Correct. That's
Okay.
where we were able to bring those rules in place because of the grants. So that's how we were
Yep.
able to do it. So, we initially got funding from Michigan Department of Human Health and Services, and then we got our SAMHSA grant. So we had initially started with just the coordinator. I think we only had one monitor, one case manager, and then we were able to expand upon that.
Okay, that's what I figured. But I do like that idea because for some people, like case management is just like super intense if that's not something that they need. And we are trying to look into looking into like those data-driven outcomes later where we really want to know, because that's my biggest question is how effective is this AOT really? And my feeling is always that I feel like it changes the behavior of the provider, which may and then hopefully change outcomes for the member. But a lot of times, at least for us, we don't always see that the members, I mean, some of them have had so many AOT orders that I think they're just like truly indifferent to it. But I would love to talk to you more. And I know we have something that we're trying to schedule in the books
Yes.
about how you're collecting that data because I would love, 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 love to get some ideas. So, all that in a nutshell. Thank you very much. I appreciate this. This is super helpful.
No problem. Jenny, I think you had put something in the chat. Let me look. Okay. Were there any systems of care that were difficult to engage? If so, how did you handle it? Yeah, I mean, there was some pushback initially with the hospitals. When I first started connecting with them, there was some questions of, well, we don't have time. I can't do this. I can't, so that's where I really came at it from tell me what you need. How can I help you? And a lot of it too was also just persistence. I keep checking in, keep asking. There were a few hospitals that we had to get some leadership involved at the hospital. Unfortunately, sometimes we had to pull the mental health code says we're supposed to be here. So we tried to use it as a last resort. I would say the other avenue I haven't felt that we've gotten pushback from our providers at all. If anything, I think it's just been trying to make sure that they know that we're here. because once we are, usually they're more than grateful. The only other thing I would say is the judges. I mean, trying to get in to get FaceTime with them to help them understand what we do, how we can help them, how we want to work together, to kind of, not be so siloed as we are. I would say those are probably, the two biggest ones. We've obviously had some, issues with law enforcement regarding, paperwork, because Oakland County utilizes my file, so everything is done via e-filing. So there's been some hiccups with some things, but I think now that we've been around for a couple of years, we've kind of solidified some different processes that we just make things go a little bit smoother. Mac asks, will the data we are collecting tell us how effective our AOT program is? What's working well? What can be improved? I mean, that's the hope, Mac. Unfortunately, with the cost saving, dashboard, it's going to take time. It's not something that, we can do, right away. It's kind of looking more long term. So that is the hope, is that we can recognize, how we're helping, how it's making a difference. I mean, I have to say, it's going to take time, but that's kind of the hope. And that's why we're collecting so much data. Some of the data we're collecting, it was kind of like, this is what we were told we had to collect. But I think a lot of it too is we would have done it anyways. And I'm not the data expert. That really is Suri and our program evaluator. We're very lucky that we have a specific person to just do that, which was a part of our grant, which we appreciate, to really manage a lot of that. But hopefully that answers your question, Max. So
Yeah,
yes.
that's fair.
I have a follow-up kind of related to the SAMHSA grant. I guess I would love to know, when you first got the SAMHSA grant, like, what was one of the biggest, I don't want to say barrier, but I think challenges, like something that you had to set up that wasn't in place already for the grant, and how did you go about that process?
I'll have to think about it, because honestly, we were ahead of the game, which is interesting because we just got back not that long ago. Myself, our program evaluator, and our director went on site to SAMHSA, to meet the other grantees, and it was interesting because so many of them didn't even have participants, and we're like, yeah, we're fully up and running. So I think we were at an advantage in that. Jody, yes, I think we were at an advantage. I think what really we had to do was, there was some paperwork we had to do, like, per the SAMHSA grant, we had some policies we had to write up, some things that we needed to do, per the grant. And I can't think of them right off the bat, but a lot of it really came down to like policies, um, getting, some permission to track some data, things like that we had to put in place. And then it was really, I think the biggest hurdle probably honestly was the data too. It was recognizing what we needed to collect, how we could do this, get this to SAMHSA. And then, like Jody had put in there, we have to do the support tool. So that was a huge undertaking, trying to understand how to do it, how to make it work, because I actually went out on maternity leave, part of when we got the grant, and we originally started using the NOMS, and that was all Jody. And then they switched, and the support rollout was interesting. We felt SAMHSA made it kind of clear they didn't know exactly everything. So I would say that's been another thing, but it's tough because we were so ahead of the game that we didn't have, I think, a lot of the hurdles that the other people did. Some of the things that I've heard from other programs were, honestly, they've said their mental health code is the biggest barrier in regards to being able to execute these services, that they got the grant, but they keep running into barriers of what they can and cannot do. Other programs talked about how it's, getting buy-in to have these people do it, because the way that they do AOT in their state is a little bit different. Our mental health code, it allows for people to be placed on an order honestly easier than a lot of other states. And so we can, have that happen. And because especially Oakland County has been doing it for quite a while, it wasn't new. So some of this was new to other, areas where they were trying to do it to get it out there. So I know it's not great answer, but I will say, I think because we had our program partially in place, I know the MDHHS grant was very helpful because it helped us really jump on starting to do it. And I think really having Genesee and having CEI already doing this was huge. We didn't have to recreate the wheel. We would have never been able to It would have been so much harder, but we really were, I mean, Genesee sent us job descriptions. I mean, they were so incredibly helpful to help us understand how to make this work because they were already doing it. And I think, that's where we also had the huge advantage that not other, grantees from the SAMHSA grant have had.
Yeah. I mean, it's fantastic to hear that you guys were in a position. It's not a bad answer to the question. And I think it's awesome that you had support from other CMHs doing it to help you out. And hopefully this space can kind of offer the same thing to other CMHs who are working to get their programs towards a place like OCHN has. And I see in the chat, somebody said that they're from Illinois, and the Michigan Mental Health Code is much more supportive of AOTs than Illinois, like you said. Well, I was going to open it up for another question, but we only have 2 minutes left. So if you have any other questions that weren't addressed here, please feel free to reach out and let us know. But your pizza is better. Well, we'll leave that up to debate, David. I won't get into that argument right now. Yes, thank you everybody for coming. Big thank you to Megan and to Jody for presenting for us today and talking about your AOT program. Shout out to all the other people from OCHN on the call that are doing fantastic work. Please do not hesitate to reach out in the next month. We will see you at our next COP on Friday, August 28th at 11 a.m. We'll send out a follow-up email with all the materials we discussed today. And I hope everybody has a fantastic and beautiful weekend.